Well, greetings everyone, and welcome to the EKG case for the week of August 26th, 2013. Well, this week we're going to do something a little bit different, and I'm going to editorialize just a little bit. Perhaps you might call this a little bit of a rant, in fact. And so I'm not going to do one of the traditional cases. I'm going to talk about one of my personal pet peeves with regards to a lot of the EKG cases that I see and hear about around our system and from elsewhere. But before I get into that, I wanted to just bring up a point with regards to medical education. You know, I kind of feel like at this point in our medical education, every time somebody throws a useless piece of information at you, or every time you memorize or remember a useless piece of clinical information, I really believe something useful falls out. And God forbid it's something really important like your wife's birth date or anniversary date or something like that. I've said that before in lectures, and I really believe that that's true. Now, I went into emergency medicine because I really wanted to save patients' lives. And I got to tell you that there is a ton of stuff that we've had to remember and learn over the years in college and medical school and residency and for the boards and everything else, which does nothing to save patients' lives. But I'll tell you what, by remembering my wife's birth date, I save one life every single year. Mine, right? So, as an example, let me just share or ask you a few questions here. All right? I'm going to ask you 4 questions. Can you name the 4 factors that cause the oxygen hemoglobin dissociation curve to shift to the right? Question number 2. What is the formula for calculating a patient's creatinine clearance? Question number 3, on which phase of the action potential do sodium channel blockers act? And question number 4, what are the 4 steps of the Brugada algorithm for determining whether a wide complex tachycardia is VTach versus SVT with aberrant conduction? Now, I have to tell you that if there's anybody out there that can answer any of these 4 questions, honestly, you really need to get a life. Honestly. And in fact, if there's some people out there, and I know there probably are, if there's some people out there that hit the pause button because you felt like you just needed a couple of more seconds to answer one of those questions, I would suggest that you take up another hobby, or a hobby, I should say, because those are useless pieces of information that have probably at some point been stuffed into your head, and certainly stuffed into my head also, and they won't help you save lives. Now, with that, we'll go ahead and we'll start talking a little bit about electrocardiography. And I want to share with you a couple of cases that were sent to me. And for some reason, just over the past few weeks, I've gotten a whole bunch of wide complex tachycardia cases and a lot of questions that were sent pertaining to trying to distinguish between VTach versus SVT with aberrant conduction. I don't know why there's been so much coming out about, or why I've been asked so many questions about this. Maybe there's some lecture out there that somebody did at a big conference or what. But I'm going to share with you a couple of the cases that were sent to me. The first case was sent by Jeff Siegler, who is a second-year resident at State University of New York up in Syracuse, and he seems to have a really strong interest in electrocardiography. I've appreciated some of the cases that he sent. He was taking care of a 76-year-old man that presented with some mid-sternal chest pain and shortness of breath. Now take a look at these risk factors. He's got a prior history of an MI. He's got a stent. He's a former smoker to the tune of developing COPD, and he's got a history of hypertension. So he shows up in the emergency department with a wide complex tachycardia. And you know what? To be honest with you, what I've learned is with all of these risk factors, I don't even need to pay attention to the wide complex tachycardia. I'm just going to look at this thing and I'm going to call it ventricular tachycardia. I'm done. I don't have to pay much more attention to it than that. And the nice thing about having that approach is very simple. Number 1, it's stress-free. I don't have to stare at that 12-lead EKG and go through all different types of algorithms and measure the distance from the beginning of the R to the nadir of the S wave, or take a look at AVR, anything else like that. I can just call it VTach. I'm done. And you know what? Even if I'm wrong and it turns out to be SVT, everything I do for that patient is still going to work. On the other hand, if I call it SVT and it in reality is VTach, I am going to kill that patient with the drugs that are often used for SVT. So I like my simple, anxiety-free approach, and not only is it anxiety-free for me, but it actually saves lives. So when he asked me about this particular case, I told him that I just assume it was ventricular tachycardia, and I don't really need to look a whole lot more. All right, so that was one of the cases that was sent in. We'll, at the very end, follow up on what happened with this particular patient. And another case was sent to me by Richard LaChance, who is a paramedic. He works in the UT Southwestern medical system. And he had a 72-year-old man that presented to the emergency department with a wide complex tachycardia. He didn't have the full history, but he just sent the 12-lead EKG. And again, he's 72 years old. Statistically, if you have an elderly patient who presents with a wide complex tachycardia and or a patient with a cardiac history with a wide complex tachycardia, there's right off the bat an 85% likelihood that you're looking at VTAC. And what's one of the things that we've all learned about these wide complex tachycardias, right? Everybody has learned these things. Every resident in any residency that exists, except, of course, maybe orthopedics, everyone else has learned these classic teachings. When you see a wide complex tachycardia, assume it's VTAC until proven otherwise. When in doubt, always assume and treat the wide complex tachycardia as VTAC. And the reason is because, just like I said, if you've got VTAC and you misdiagnose as SVT, you can kill them. On the other hand, if it's SVT and you mistakenly call it VTAC, you know what? Everything's fine, because oftentimes, for the most part, the drugs that you use for VTAC are not going to hurt an SVT patient. And if you go down that VTAC algorithm, you're going to end up doing the right thing. And this is another key point that throws a lot of people off. This teaching applies regardless of hemodynamic stability, regardless of the patient's age or cardiac risk factors. Even if you've got a 25, 30, 35, 40-year-old patient who's hemodynamically stable, you still have to assume it's VTAC. And I've seen many cases, and I'm not exaggerating either, just from the cases that I've seen, cases that other people have sent, relatively young people with no prior cardiac history who sure as heck have ventricular tachycardia. You've got to assume it's VTAC, all right? And it says here, until proven otherwise, I would prefer to just get rid of that. Don't even try to prove otherwise, all right? And you should always be in doubt. Just assume it is ventricular tachycardia. Now, despite these common teachings, a handful of people have tried to come up with various algorithms that could reliably tell you when somebody has VTAC, which we were already assuming, but presumably these can also tell you when somebody has SVT. And if you use these algorithms, and if they worked, you could reliably tell that somebody with a wide complex tachycardia has SVT, and you can just go ahead and give them the verapamil or diltiazem. Probably the most famous of these algorithms was the Brugada criteria, published way back in 91, and this is one of the things that was drilled into my head, and I was told that I had to know this for the boards. Turned out not to be true. But anyway, this is a somewhat complicated 4-step algorithm, and in the original studies, it looked really good. Take a look at this. Sensitivity for picking up VTAC, 98.7%, which means that you only misdiagnose and kill 1.3% of your patients. Maybe that's not too bad. We can argue that. But the problem with this is that it is a complicated algorithm. And if you're working in an emergency department, you don't have time to sit there and run through a complicated 4-step algorithm. And again, these are not just 4 simple questions. I'm not going to go through the details here. Just Google search this, and you'll see how complicated some of these things are. Measuring out the intervals, and there's very specific morphology criteria that you need to look for, multiple morphology criteria, before you can pass it off as an SVT. Well, just to highlight or to prove how complicated this is, it's been studied. Mel Herbert took a look at 27 wide complex tachycardias from ED records, gave it to 3 emergency physicians. 22% of the cases, they disagreed. They couldn't, using an open book format, they couldn't come up with agreement on whether the patients had wide complex tachycardia due to VTAC or due to SVT with aberrant conduction. 22% of the time, they're sitting there holding a cup of coffee and they can't figure out or they can't come to an agreement. All right. Well, Jennifer Eisenhower did a great study in which they used electrophysiology testing as the gold standard. So that's about the best gold standard that you've got. 157 EKGs. She gave them not only to two cardiologists, but also two not only two emergency physicians, but also two cardiologists. She gave them Brugada's criteria and said, figure out whether this is VTAC or SVT. Well, the emergency physicians one of them missed 17%, the other missed 21% of VTAC cases. IA is inter-observer agreement, so they disagreed 18% of the time. Cardiologists didn't do a whole lot better. One cardiologist missed 15%, the other cardiologist missed 9% of cases of VTAC, which means that even these cardiologists, if they use Brugada's criteria to decide who can get the calcium channel blocker or beta blocker, 15% and 9% of patients would have ended up deteriorating, and in almost 20% of cases, they ended up disagreeing with each other. Bottom line is Brugada's criteria, it's difficult, and the studies don't back it up. There's a couple of other criteria that have come out, which are very highly touted. Varecki came up with two algorithms. In one algorithm, he just specifically looked at AVR. Well, at American Heart Association's national conference just a few years ago, a group of researchers headed up by Sasaki took a look at the Brugada and the Varecki AVR algorithm. They took 71 proven cases of VTAC and they ran them through these algorithms to find out which is the best algorithm. Take a look at their results. Brugada's algorithm missed 14% of cases of VTAC. Varecki's algorithm missed 24%. Varecki AVR algorithm missed 14%. So even in these cases, Brugada and the Varecki's algorithms are missing a lot of cases of ventricular tachycardia. Now remember, these studies are being done in control settings, not in a busy emergency department with patients yelling out and screaming, and you've got more and more patients coming in the door, and you're rushing to figure out what to do with this patient and the 20 others that are waiting. These algorithms just don't work reliably enough. And then the most recent study that I've seen looking at these algorithms was by Jastrzeebski, I hope I'm getting that name right, and published in Europace, which is an electrophysiology European journal. They looked at the accuracies at diagnosing various wide complex tachycardias. They looked at the Brugada and a few other algorithms. They looked at Varecki, we talked about that, but also the Bayesian algorithm, the Griffith algorithm, which I've actually heard is the best one of all, is a recent one, and then a kind of complicated lead to R-wave peak time algorithm. They came up with 260 wide complex tachycardias, 159 of which were EP-proven ventricular tachycardia. And so what were the sensitivities of these various algorithms? Take a look. Brugada's algorithm missed 11% of ventricular tachycardia. Griffith was the best. It only missed 6%, but it had the worst specificity. So the reason it missed 6% is because it pretty much called everything VTAC, right? Bayesian missed 11%. Varecki, once again, missed 13%. And this lead to R-wave whatever thing, it missed 40% of ventricular tachycardia cases. The bottom line is these algorithms stink. If you're using these algorithms to try to come up with diagnoses of whether somebody has SVT versus ventricular tachycardia, even the very best and most highly touted algorithm, the Brugada algorithm, is going to miss 11% of cases of VTAC. Now, this is a deadly diagnosis. How long do you think you're going to have a job if you miss 11% of deadly diagnoses? Not for very long. A lot of patients are going to end up dying. The bottom line is that while it's true that we have many reliable criteria that rule in VTAC, well, who cares? We've already been told to assume it's VTAC. What I would like is criteria that rule it out, and there are no reliable criteria that rule it out, maybe with one exception, and here it is. If you get a wide complex tachycardia, and you also, for example, what you see up here, and you also happen to have the baseline 12 lead. Take a look. The baseline 12 lead has QRS complexes that are pretty much identical essentially in all of the 12 leads as during the tachycardia. In that scenario, the person's got a baseline right bundle branch block, and when they go into the tachycardia, the morphologies stay the same. In this case, go ahead and assume it's an SVT with a bundle or a right bundle in this particular case. Give them the adenosine, the calcium channel blocker, the beta blocker, whatever you want. But if you don't have a baseline, or if you have a baseline and the QRS morphologies have changed, you've got to assume you're dealing with ventricular tachycardia. It's the safest thing to do, and if you're wrong, you're going to kill somebody, all right? So I would like to propose my two-step algorithm. I'm going to call this the MATU algorithm for wide complex tachycardias. You know, I've always wanted to have my name on an algorithm of some type, and, well, I don't know. Anyway, here's my two-step algorithm. It's easy, 2 steps. Anybody can remember 2 steps, right? So here's what you do. 2 simple questions. Question number 1, ask yourself, is the wide complex tachycardia clearly sinus tach with aberrancy? And I underline clearly. There should be no doubt. Yeah, if you're dealing with sinus tachycardia, then fine. Just treat the underlying cause, call it sinus tach, and you're done, right? But if it's not clearly sinus tachycardia, in other words, you have a wide complex tachycardia that's not just plain old benign old sinus, then you move to step number 2. Step number 2 is it's VTach. You're done. It's 2 steps and you're done. If it's not sinus tach, you've got to call it ventricular tachycardia. How easy and stress-free is that? A 2-step algorithm, if it's not sinus tach, it's VTach. You're done. You don't have to think about this any longer. And you know what? Not only is it easy and stress-free, but if you follow this, you will save lives. It's that simple. All right? Now, let's go back to the cases that we started with. Jeff Ziegler had sent this case. I didn't tell you what happened with this patient's wide complex tachycardia. He ended up cardioverting himself when he started coughing, and so that's kind of a clue. This guy with all the cardiac risk factors, no doubt, no surprise, had triple vessel disease. And actually, if you run him through the Brugada algorithm and 1 or 2 of the other algorithms, it comes out that he's got SVT with aberrant conduction. But in a 76-year-old guy with multiple cardiac risk factors, and he ended up having a cath showing triple vessel disease, would you ever assume that you're dealing with SVT with aberrant conduction? No way. You've got to assume that this patient's got ventricular tachycardia and treat it as such until he gets the EP test, which is the confirmatory test. And in this case, go figure, his EP test did show that he had SVT with aberrant conduction. But no way would you ever be justified in assuming this guy's got SVT with aberrant conduction with all those cardiac risk factors. That would be crazy, even if he is hemodynamically stable. Well, the fact that he converted after coughing is a bit of a clue, but even the cardiologist there felt compelled to take him all the way to the EP test because they were smart enough to know that nothing in his presentation and nothing on that 12-lead EKG is definitive enough to just be done and call this guy SVT with aberrant conduction. So kudos to the cardiologist there for being aggressive and going all the way to the confirmatory test, which is an EP test. Second case by Richard LaChance. This was the 72-year-old, and this actually proved to be ventricular tachycardia, and there's a very nice sign if you need any more evidence to just call something VTach. This person's got something called Josephson's sign, I'll get that pronunciation, and essentially it's just a little hitch there. You see how the S wave is coming down and then it hitches. That little hitch right there is called Josephson's. I'm going to practice that name, Josephson's sign, and that is enormously predictive of ventricular tachycardia. So again, you should probably just assume it's VTach right from the start anyway, but if you need further proof, that's what that sign is called, and it's another helpful clue. So take-home points. Just call it VTach. You're done. And if you get in the habit of taking wide complex tachycardias and just get in the habit of assuming it's VTach, look at the results. There's less stress for you, you're going to save more patients' lives, and you're going to be able to remember your spouse's birthday because you're not going to clutter your brain with useless algorithms that are going to mislead you and make you kill 11% of the patients that you take care of because you followed a faulty algorithm. Now, one question that we'll address next week, I know some of you might be thinking, well, what about just using adenosine as a diagnostic challenge, right? There's some literature that says give them adenosine. If they convert, it's SVT. If they don't convert, then move forward with the VTach algorithm. And I'm getting chest pain just thinking about that. We're going to talk about that next week, all right? So I hope this week's case, even though it was a little bit different, I hope it was helpful. And I'm sure that probably there's some people out there some purist EKG people out there that are probably a little bit insulted or a little bit unhappy with what I'm saying here about wide complex tachycardias, but I don't care. I don't consider myself a purist. I consider myself a pragmatist electrocardiography person, and I want to only teach stuff that's practical. And it always makes me shudder in board courses and lectures when people start talking about all these different algorithms, because the literature says that if you use the algorithms, even when the cardiologists themselves use the algorithms, even in controlled research settings where there's no rush and no pressure to move patients, you just sit down with your coffee, you take your time, and you run through the algorithm, no rush, you're still going to miss 11% or more of your proven cases of VTAC. And missing 11% of cases of VTAC and potentially killing 11% of your cases of VTAC, that is completely unacceptable. So, my recommendation, again, no offense to anyone out there, although some people I'm sure are unhappy with what I'm saying, my recommendation is, when you see a wide complex tachycardia, if it's not clearly sinus tachycardia, just assume you're dealing with VTAC. Don't give it any more thought, and give him your lidocaine and procainamide, or just go right to electrical cardioversion, and you will not only be stress-free, but you are going to save lives and remember your wife's birthday. That's it for this week. We'll talk about adenosine next week. Bye for now.